So next we have our keynote address. Dr. Wendy Wow, I'm going to now talk about my primary care doctor, apparently. Dr. Wendy Chapkus, if you'd like to come up, please.
Well, good morning, and thank you to everyone who came out this morning. I also want to thank everyone at UNE who made today's event possible, and I especially want to thank Zoe Brokus and Lorena, I believe her last name is pronounced La Liberty, who is from AdCare. They helped ensure that I could bring 25 students from USM who are here today doing a low-credit, one-day social justice pop-up course. So that's really fantastic. Some of those students almost didn't get in because, as you may know, organizers had to close registration early because there was such an overwhelming interest in this event. And I think there's great evidence that there's a need and a hunger for the kind of information that we're going to get today, which speaks both to the public health crisis that we're facing and also to the kind of community that we're all lucky enough to live in. We are surrounded in these difficult times by people who actually do care. And I want to invoke one of those people, David Zisk. I met David at one of these harm reduction conferences in Portland maybe 3 or 4 years ago. He was such a compelling and charismatic speaker that I was convinced when I was thinking back over the event that he had been the keynote. Apparently he wasn't, but whatever his role was, when I was asked to give the keynote this year, I thought, oh, I have some big shoes to fill. As I said, David made a really lasting impression, and I was shocked and heartbroken when he died a couple of years ago, just months before graduating with a BA in social work from the University of Southern Maine with a 3.98 grade point average. His mother told the press that after 4 years of sobriety, David died from a one-time relapse, but he would hate that word relapse, she said. His obituary noted that David's goals were to change policies and public perceptions of drug addiction and drug users. So this morning I want to invoke David as we carry on with that incredibly important work of changing policies toward and perceptions of drug users and all other people who are at risk of preventable harm. It's clear to me that if someone as determined and well-informed as David can die using drugs, then drug overdose is not just about an individual lack of willpower or faulty morals, but instead is a shameful, collective, public policy failure. And I'm going to devote my time this morning to providing a few examples and offering some evidence for why I've come to this conclusion. Evidence really matters to me. I'm trained as a social scientist, and I am appalled by the neglect in this country of evidence-based public policy. As you can see already, probably this is going to be no dispassionate scholarly treatise on harm reduction. I'm sure we're going to hear many of those today, and I'm looking forward to them. But I personally am too angry, and I'm too engaged for that. I'm going to be making some highly charged statements today, and as a scholar, I will support them with facts. But these facts demand action, and getting active means that you can no longer be neutral. I agree with historian Howard Zinn, who famously said, "You can't be neutral on a moving train," and this train is definitely moving, and it's leaving a trail of death in its wake. Taking action is, of course, itself a form of risk-taking. Those of us who are university faculty are acutely aware of those risks right now. For example, as some of you may know, last year the University of Maine Board of Trustees passed a new so-called free speech policy that actually restricts speech on politically charged issues. Ostensibly, it was directed at presidents of the various campuses, but faculty in the UMaine system knew we would be experiencing its chilling and punitive effects as well. And we have, as you surely know if you have been following the local news over the past couple of weeks. So I suppose, from the outset, I should make clear that I am speaking for myself as someone with scholarly expertise, but who only happens to teach at the University of Southern Maine. I in no way pretend to represent the views of the institution or its Board of Trustees, nor should they pretend to represent mine. So, like our previous speaker, my first harm reduction strategy is to urge you to vote, because we need to make dissent safe again in the state of Maine and in this country. So please, on November 6th. There is no ranked choice for governor, that is correct. Okay, absolutely. Okay, so one of the things I think we need to do in this upcoming election is vote for people who believe in and support evidence-based social policy. They are our social policy makers. And after studying the evidence in this field, it is clear to me that far too often, social policies in this country, including those focused on risky sex and drug use, are explicitly designed, I believe, to reinforce and sometimes even enhance risk. Now, we can debate whether that is a deliberate social policy or an inadvertent one, but in either case, the effect has been and continues to be disastrous for public health. My own areas of scholarship focus on what used to be called vice crime, prostitution and drug use. In doing research on those issues, it quickly became apparent to me that illicit sex and illicit drug use are still considered moral violations in this country, and efforts to discourage participation in these practices rely heavily on strategies of shame, marginalization, and punishment. Through these policies of prohibition, we criminalize prostitutes, addicts, and others, ostensibly for participants' own good and for the good of society at large. These practices are prohibited not only because they're risky to the participants and to public health, but also because they are defined as wrong. And the need to keep them wrong trumps the need to make them safer, because risk could be reduced. But policies in the United States most often don't even try to reduce harm. Instead, and shockingly, policies are enacted and enforced and defended that ensure that sex and drugs remain as dangerous as possible. This harm reinforcement policy is justified on the grounds that reducing risk would encourage bad behavior, while maintaining or even enhancing risk will serve to dissuade those otherwise tempted to participate in stigmatized practices. Those who fail to resist temptation must suffer the consequences so that they can then be offered up as an abject lesson to the rest of us about unacceptable risks and the need to police our behaviors. Let me give you some evidence for all of this. After more than 40 years of the war on drugs, with its focus on drug interdiction and drug use prohibition and criminalization of drug users, the United States is the #1 country in the world in illegal drug use. The #1 country in the world for drug use. Drugs are still widely available, both through the underground economy and through big pharma. Not only that, some drugs are even cheaper and more widely available than they were before the war on drugs began. To give just one example, I learned that cocaine is now 74% cheaper than it was 4 decades ago. Now, this failure is especially striking given the fact that the U.S. has invested billions and billions and billions of taxpayer dollars on these ineffective efforts to prohibit and punish drug use. Currently, the U.S. is spending $58 billion a year on the war on drugs. And while strategies of prohibition and punishment haven't stopped drug use or drug production or drug sales, they have had a huge impact on one area of our society, our prisons. More than 1.5 million people were arrested last year alone for drug law violations. 85% of them were charged with possession only. Largely because of this, the U.S. now has the largest prison population in the world. Mass incarceration associated with drug use also represents, as Richard Branson has said, quote, racial discrimination disguised as drug policy. Because while people of color are no more likely to use or sell drugs, they are arrested and incarcerated for drug offenses at rates many times higher than those of white Americans. These policies are not only exacerbating racial inequality in this country and enriching the private prison industry, they're also killing a lot of us. The U.S. accounts for 1 out of every 4 drug-related deaths in the world. In 2016, there were almost 65,000 drug overdose deaths in this country. That was in a 1-year period, 65,000. And to just give you some comparison, that same year, there were 9,000 overdose deaths in all 28 European Union countries, Turkey and Norway combined. In fact, it took the European Union an entire decade to get to the number of drug overdose deaths that happened in this country in that 1 year. And the real point is almost all of those deaths could have been avoided. So why are American drug users getting sick and dying at so much higher rates than other comparable countries? In part, it's because our government refuses to implement evidence-based policies that have been proven effective in saving lives and protecting health. Let me mention just a few of the most effective policies implemented elsewhere, but banned or grossly underfunded in the United States. Let me emphasize that point. In this country, when these life-saving interventions are available, it's almost always through underfunded grassroots efforts or local and state governments. Far too often, the U.S. federal government has been an impediment to the implementation of good social policy. Here's some examples. Because drugs are prohibited, users have a very difficult time really knowing what it is they're ingesting or injecting. There are existing strategies to address this problem, most notably access to testing of illicit drugs. The organization DanceSafe, for example, attempts to test drugs like ecstasy at social venues known for drug use, like concerts or raves. But they risk arrest in doing so. DanceSafe was created in 1998, and it was modeled on a Dutch government-funded pill testing program. DanceSafe has 25 chapters in the US and Canada now, but rather than support this life-saving strategy, and inexplicably to me, the US Senate and House passed a law initially known as the RAVE Act that makes it illegal for event promoters to offer harm reduction and drug education services like DanceSafe at their events. Another form of harm reduction that should be much more widely embraced and supported in the midst of an overdose epidemic is fentanyl test strips. A recent study in the US concluded that illicit markets for opiates are basically poisoned by synthetic opioids like fentanyl. Because these drugs can be many times more powerful than the heroin to which they are added, they are the key culprit in a record number of deaths among US opiate users. Under these circumstances, being able to test your drugs before using them is critical as a public health intervention. But there is no support from the US federal government. Instead, cities are having to take the lead. In just the past 10 months alone, a few cities like Baltimore and Philadelphia and Burlington have purchased more than 650,000 fentanyl test strips and made them available to people who use these drugs so they can better know what they're ingesting. Despite the epidemic of overdose deaths in the US, the federal government and its public health agencies have not made this $1 life-saving tool a priority. Another life-saving strategy long resisted by the US federal government is the provision of sterile needles and syringes to injection drug users. Clean needles have been shown to prevent transmission of pathogens like hepatitis C and HIV, but instead of embracing this relatively inexpensive intervention, and in the face of a deadly HIV epidemic, the US federal government prohibited any federal funding for needle exchange programs from 1988, at the height of the AIDS epidemic, to 2015. This resulted in the deaths of tens of thousands of injection drug users from AIDS. It wasn't until 2 years ago that our federal government gave states and local communities the opportunity to use some federal funds to support needle and syringe programs. But they're still not allowed to use those funds to actually pay for the needles or syringes. And the feds are not the only ones with blood on their hands in this regard. There are 15 states in this country who currently completely outlaw needle exchange programs. Because of government policy impeding public health interventions, Americans who inject drugs are 4 times more likely to have HIV than injection drug users in countries like Britain, where there's been government-supported needle exchange programs since the 1980s. Americans are 6 times more likely than Swiss injection drug users to be HIV positive. And this is especially notable because in the 1980s, Switzerland had one of the highest rates of heroin addiction and a faster than average spread of HIV. But unlike the US federal response, the Swiss federal authorities immediately introduced radical harm reduction policies that included things like vending machines for clean needles and syringes, and safe injection rooms where IV drug users could get clean needles, be connected with social services, and if they had an accidental overdose, be revived with Narcan or naloxone. The result was that new cases of HIV plummeted, as did overdose rates. And today, nearly every city in Switzerland has government-funded needle exchange and safe injection sites. And far from encouraging opiate use, studies show that these policies have helped IV drug users in Switzerland find their way into treatment. Switzerland now has the world's highest rate of those with heroin dependency receiving treatment through substitution therapies like methadone, about 90%. And equally impressive is the fact that new heroin addicts are exceptionally rare in Switzerland. Switzerland is not the only country that has implemented effective evidence-based policies like these. More close to home, Canada, for example, has moved much more decisively than the United States in the direction of harm reduction creating, for example, supervised injection sites. One study in Vancouver showed a 35% reduction in overdose deaths in areas that had safe injection sites. In addition, 1 out of every 4 people who used those sites went into recovery and stopped injecting drugs. In the US, by contrast, supervised injection sites are prohibited by the federal government. Recently, state legislators in California passed a law that would have allowed them to open these facilities in that state, but the measure was vetoed by Governor Jerry Brown, who noted that US Attorney General Jeff Sessions has threatened federal prosecution of local officials and health professionals should they participate in supervised injection sites. Given these harm reinforcement strategies in the United States, the final line of defense in overdose deaths, naloxone, becomes all the more critical. At least in this area, the federal government has not prohibited access to this life-saving treatment. And it even allows the states to use some federal funding to purchase Narcan. But those purchases compete with other prevention and treatment priorities. And this is because of the $58 billion we're spending this year on the war on drugs, less than $2 billion is available to all of the states for treatment and prevention. This isn't the first time in my life that I've witnessed the US federal government prioritize morality and ideology over effective public health policies. I came of age at the height of the AIDS epidemic in the 1980s, and I watched my friends get sick and die, and I was stunned by the lack of concern, much less support, by the government. Whenever I hear Ronald Reagan extolled as a great president, I remember that he not only failed to even utter the word AIDS until several years into the AIDS epidemic, and after more than 14,000 people had died, but even then, it was to say that prevention was better than a cure, and to blame those who were already sick for their illness because, according to Reagan, abstinence had been lacking. I remember the great relief I felt when his Surgeon General, C. Everett Koop, reminded the nation that the business of government should be saving lives, not saving souls. But even then, paltry resources were made available for research and treatment until we demanded them by laying our bodies in the streets and by occupying government and corporate offices. So I've lived this nightmare before, when the government turns its back on people who are sick because of their supposed moral failings. Then, as now, policymakers and politicians justified keeping risks so high because they saw the people most effective as already, always sick. Their deaths were understood to be more or less inevitable, maybe even beneficial to society at large, representing a sort of cleansing of those people. The rhetoric and policy failures in the face of the overdose epidemic of our time echoes those of the AIDS plague years. Locally, as our Maine Governor Paul LePage has so memorably said when he vetoed a 2016 bill that would have expanded access to naloxone without prescription, quote, "Naloxone doesn't truly save lives, it merely extends them until the next overdose." Like homosexuals who only had themselves to blame for AIDS, LePage seemed to suggest that addicts who couldn't will themselves to wellness shouldn't be kept alive. After the legislature overrode at least part of that veto, LePage admitted that perhaps naloxone would save some lives, but still he struggled with the question of whether those lives were really worth the cost of savings. of saving. Despite admitting that he had, quote, finally come to the realization you can't put a price on life, he went ahead and did so. According to LePage, we have to say when we give you a shot, you have to go to rehab or pay for it. As we just heard, generic naloxone costs about $40 a dose, brand name Narcan about $70. So the money that we're spending on reviving people is more than taxpayers should have to pay, according to some of our public officials. Of course, those same officials have not only tried to block access to this life-saving drug or to pass the costs off on those who are struggling with drug dependency, but have also prevented, in LePage's case, the implementation of a range of other initiatives that have been approved by the legislature or passed by the voters, most notably expanding access to health care through the expansion of Medicaid, a policy that would make it easier for people to get into treatment if they needed it and wanted it. As I said at the beginning of my remarks, actively blocking public health interventions that save lives and embracing punitive ones that fail to do so means that too many elected officials continue to believe that harm is a resource, not a problem. Those unwilling or unable to be abstinent are left to die because their lives are worthless and their deaths are seen as useful. What other conclusion can we come to when we know that there are existing, evidence-based, effective social policies that can dramatically reduce risks and harms, but our government chooses not to implement them and instead doubles down on policies that are proven to cause harm? This is unconscionable. We must change this trajectory. Thank you.